To our webcast. This is Guy Mansetto. I'm Vice President of Marketing for FITEL. I'm also a co-chair on the Center for Multi-Stakeholder Demonstrations within the PCPCC Collaborative. Today's session is entitled Affinity's Medical Home Journey, Operational, Clinical, and Financial Perspectives, presented by Dr. Christine Griger, President of Affinity Medical Group, Tim Loch, Chief Operating Officer, and Jane Curran, Regional Director of Clinical Operations. Affinity Medical Group is a team of more than 250 healthcare professionals providing medical care through its network of 26 clinics in 12 Northeast Wisconsin communities. All lines have been placed on mute to prevent any background noise. Today's presentation will last approximately 40 minutes, and there will be time available at the end of the presentation for questions and answers using the bottom portion of your GoToWebinar controls. It is my pleasure to introduce to you Affinity Medical Group.
Hi everyone, this is Chris Griger, and I'm going to start out with a little bit of an overview of Affinity. The health system is among the top 100 integrated healthcare networks in the nation. It's an organization that's sponsored by Ministry Healthcare and Wheaton Franciscan Healthcare. We have Affinity Medical Group, which is, was described as over 250 providers, employed multi-specialty group, and we're in the Fox Valley area of Wisconsin. We also have close to 900 non-provider employees. We have 23 primary care sites, and of these, currently 13 are Level 3 NCQA accredited. 9 have been submitted and we're waiting to hear, and we have one more that will be submitted in the next couple of weeks. And Jane is going to talk a little bit more about NCQA with us. There are also 3 hospitals in the system, and we have our own insurance company, Network Health Plan, which has 135,000 members. This used to be a closed system, but now is an open one, and Affinity Medical Group, about 30% of our business is with Network Health Plan. So on to the next slide, our agenda today, we're going to talk about establishing the vision and championship for our medical home implementation and the key role of the champion. We're a lean organization, and we'll talk about using the HOSHN process and various teams to implement. Talk about the team roles, including selection, role changes from the old model, wage differentials, and some other details. Key to what we've done is the health plan partnership, and we'll talk about that. We'll also talk about physician compensation in the medical home, and then finish up with lessons learned and what we see as our next steps. So next slide. This we jokingly call the wonder years. This is our childhood or our early adolescence maybe. We saw medical home, as I'm guessing everyone on the call probably does, is the way to improve quality and the delivery of care in the face of a primary care shortage, and we believe this is how medical care will be delivered in the future. A key starting point for us was a physician leader with this vision. And this is my predecessor, Dr. Rick Emus, who had the vision of medical home. And he was able to convince senior leadership within the health system to be supportive of the vision. One of the things that we learned along the way with this is the key role of physician leadership, and we'll talk a little bit about that. It was also really important to have top executive level support. The system as a whole is really bought into this concept. So we started with pilots at 2 primary care sites. Kukana site was originally 2 providers, later added a nurse practitioner, and was new family medicine, new practices, and so they were growing. And the Kohler Internal Medicine site was a site that had several providers leave, had a very large burden of sick patients, and was a site that was struggling to care for these patients. We added 1 nurse practitioner, and then a little later another one. So both of these were relatively small sites to start, and there were eventually 3 providers at each site. We partnered with Network Health Plan from the start because they also bought into the vision that medical home is a way to improve access, costs, and quality. We really feel that this strategy aligns our system brand promise of personalized care with the care delivery model. And our promise is to provide personalized care by listening, treating you with respect, and putting your needs and interests first, which really meshes with the patient-centered medical home model. We also have found that this has allowed us to differentiate Affinity in a pretty competitive healthcare market by being first to market. Just an overview of challenges. This is really a cultural paradigm shift. First of all, in transitioning from a physician-centric organization to a patient-centric organization, and that's a journey that I think we'll all be on for a long time, but we're certainly working on it. And also the idea of a team focus from the physician as captain of the ship to physician-led but team-based and patient-centered, and that's a much bigger cultural change than you can encapsulate in a few words. We needed the alignment of our 100-plus PCPs for support of this vision. We also realized early on, and we'll talk a little bit about this, that we needed a compensation structure that aligned the providers with the outcomes we were trying to achieve. One of the things that we did in the very beginning as we went from pilots to overall implementation was to have a retreat of all the primary care providers to talk about why medical home, what we're going to do, how we're going to do it. Another one of our challenges is just our geography. As we mentioned, we have 23 sites, but a fair geographic radius of about 50 miles. The other thing that happened was Dr. Emus left, and the medical group was without a president for 9-10 months, which led the group to understand the importance of having a physician champion for the overall implementation. So at this point, I'm going to turn it over to Jane, who will continue.
As Dr. Griger said, we're a lean organization, so HOSHN process is something that's very important to us. HOSHN CANRE is really must do, can't fail. It is strategic. It is how we use our strategic planning within Affinity Health System. And what we do is we create a series of 90-day HOSHN projects that allow us to get things accomplished. They guide us on our journey. And this has been such an important piece that it's actually been a top Affinity HOSHN for the last 2 years. What the HOSHN process, though, does is allows us to prioritize resources within the system. So when there's conflict of need for, let's say, information system support, when that conflict comes up to the surface, the person who has the HOSHN that's approved by the system gets the resources they need to accomplish that task. We also found that it was really important to have ownership of the process at each site, and this was key to the success. We did not use project managers to get this accomplished. We felt it had to go back to the directors as they led their sites. We were always moving towards NCQA accreditation because we used the standards from NCQA really as our vision and how we were measuring ourselves and the goals that we identified that we need to move forward with. After we did the pilots, we actually decided that we would not go forward with NCQA accreditation because we did not have an EHR in place, and we were afraid that without the electronic health record, we were going to struggle to get the data that we needed. And at that point, we reconvened an additional HOSHN to refocus our energies and get some of the data that we did need. So once we were, our future was really contingent on, for funding, was contingent on becoming NCQA accredited. At that point, we did choose to pursue it, that NCQA accreditation. And that really leads to our structure and functions within this process. As Dr. Griger said, really having that physician leader was key to our success. Without that leadership, we did struggle a little bit. We didn't know which way to go, how to get everyone on board with that central vision. And so having one person able to speak to the medical staff on what that vision was was key. As our pilot sessions rolled out, though, we did find that we designated those pilot site physicians as our champions for the future. They helped us when going to other sites as they were getting ready to roll out. These physician champions would go and talk about the journey, would talk about the struggles on a physician-to-physician level so that they understood the implications of all these changes on their practices. Another core point of our process is having core teams. A core team is integral to every piece or every time we do a HOSHN, because that's the team that guides the direction. One thing you need to realize within Affinity, we have what we refer to as a dual path organizational structure. It's operational and medical directors work together as a team. So each operational leader at every level has a medical director at the same level who works with them in partnership to focus really on what's best for the patient, taking in the needs of the provider side, taking in the needs of the organization side, but keeping the patient as the center part of that focus. They're also, that core team is responsible for the evolution. Where is the medical home going from here? What are we going to do next? Things such as pulmonologists have come forward and said, well, we want to implement a COPD initiative within every medical home to improve the care for our COPD patients. Well, that needs to go back to the core team so that they have truly can delegate the right resources, determine what is the priority, and determine what sites will take on that task. Then we have a coordination team, and the coordination team is really the team that makes all the work happen. They were focused on the NCQA standards. We did apply under the 2008 standards, not under the 2011 standards, based on the timeline when we started this process. And we felt it was much easier to put all of our sites under the same standard than change our standards partway through the process. We were, again, very concerned that without an EHR, we would not be able to succeed with NCQA accreditation. I will tell you it is doable, but it is definitely harder without the EHR being present in terms of being able to pull data to support the proof that you're doing the right NCQA processes. We also use PHITEL to proactively call our patients to assist in the management of both our chronic disease and preventive population management, to get those patients into our system to make sure that we were doing the right things. And we aligned the PHITEL protocols with what we identified as our top diagnosis that we needed to work on. We then really looked at the site-based medical home teams. And we chose individual sites versus applying as Affinity Medical Group all as one big site, because we did not want sites who might be struggling as we came forward as medical home to hold back those who were really doing well. We used the NCQA standards that identify gaps to the care and to develop what our roadmap was at each site. And it was specific to the sites. One site may have already been doing very well in one process, but need to focus on another. So it's not something that every site needs to focus on every piece or every aspect of the standards. We are a lean organization, so that's part of our culture. So one of the things that you'll notice in our process, and we found key to our process, was creating our flow diagrams of what processes occurred. And these flows actually became so important that they're posted all over the walls. They're in our hallways. Staff refer to them frequently. They modify what they're doing and adjust things as they need to. But we also found that these flow processes became part of our orientation manual. So as new employees came on board, as physicians came on board, they could take these flow processes and understand what we did within the clinic to get things accomplished. We're also now in the process of implementing an electronic health record, and we found that these flow processes and our medical home processes actually were very complementary of each other, and we use these same workflow processes to help implement our medical home and our EHR. For team roles, when we sit back and talk about what was key for us in the medical home, the role of the the group being a team was one of those critical factors to success or failure of each individual site. Some of the things that we did is to develop the team, we actually did behavioral-based interviewing. We had to take time to go through and train each staff member so that they understood what they were actually interviewing for, what those behavioral characteristics. And we took a focus away from hiring for skills, because a lot of times we felt we could teach the skills, but we couldn't teach some of those core behavioral actions, and so we felt that those we had to hire for, and we would go back and focus on teaching skills. And for most part, that has worked very, very well for us. Our pilot sites, one of the things that we did to make this successful is we went through and made everyone reapply for their jobs. And there are pros and cons to that. The pro is that you have people who really want to be involved. You have a brand new team. They develop coming together. There are no old habits in the way. They really evolved together as the medical home came about. As our additional sites came up, we did not have staff rehire for their jobs other than our RN specialists. And I'll explain what the RN specialist is as we go into this a little bit more. And that created a whole set of new issues that we hadn't anticipated, because then we had old habits that were in place. We had dynamics that had been long established, and we had to kind of counter those dynamics. So there were some difficulties with not rehiring everybody, but we did work through those. Another important part of the team is really the huddles. Every day, the team gathers for about 5 minutes in most cases. They vary the times that they meet depending on what works best for the site. But that huddle is important for team development, and it also is important in terms of supporting the team and how the team is functioning. It also allows the team to do rapid deployment of new processes and react to things that they need to react to. Instead of taking 4 weeks to get something new in place, they're able to try something new because they instituted a huddle and all agreed and moved forward at that time. As you can see with our roles, we have physicians and APPs. APPs are advanced practice providers. They are our nurse practitioners and our physician assistants. Our physicians made a decision very early on in this process that our APPs were not support staff to them, but were complementary to their practice. So they work in partnership with the physicians. So the APPs carry their own panel. And the physicians, the other thing that came out from the physician perspective is the physicians did not want to just deal with chronic disease the rest of their practices. They find the acute processes were challenging for them. They liked that, gave them some diversity in their day. And so by having the APPs as partners, the physicians and the APPs both manage chronic disease and then the acutes that come in. And that's been a satisfier for all. Our RN specialist is a role unique to Affinity. It's what we have evolved in this process was to help support the practice. Our RN specialists meet with the patients either individually or in follow-up to a physician. So if a patient who's let's give an example, a new diabetic comes in today, the physician may see the patient, diagnose them, and ask the RN specialist to come in and do some baseline education of that patient. Or the physician may say, I want you to follow up in 3 months from now and have a visit just with the RN specialist to review your care, how things are going, and do a more of a monitoring process. What we found in some of our practices is the RN specialists have not taken work off the physicians because the physicians hadn't had time to do some of that in-depth education, so it's really improved the quality of those practices, where in other practices the RN specialists have taken some burden off the physician load, and thus it's improved the efficiency of the practice because the physician can now see more patients with the help of the RN specialist. Our RN specialist ratio, we struggled a little bit with what's the right staffing ratio for our practices, and we tried several different methods of figuring out the best staffing patterns. And what we found is since they were the group that was managing our chronic and preventative patient panels, that their staffing ratio were based off the provider panel sizes. So for family medicine and pediatrics, we had about 1 FTE of RN specialists for every 6,000 to 7,000 patients. For our internal medicine specialists, we had about 1 FTE of RN specialists for every 3,000 to 4,000 patients on the panel. The next role that we have is a behavioral health coordinator. And the behavioral health coordinator actually sees patients both with behavioral health issues, but also with issues that are barriers to their management of their chronic diseases. These behavioral health coordinators are seeing patients on a daily basis, have regularly scheduled patients. They also are stopping in to assist with things that occur in the practice, but also they're there to support the development of the team, the functionality of the team. So they have more than just a patient care base. They're also helping to manage the medical home team. What we did do from a patient care standpoint, though, is the behavioral health specialist sees up to 6 visits, depending on what's appropriate for that patient. And after that point, then they're referred to a psychologist or a psychiatrist, depending on what's appropriate for that patient. We have found, though, that more patients are utilizing this service because they're not having to go with the stigma of seeking out behavioral health care. They're going to their primary care provider's office and getting the care that they need. The healthcare coordinator, or excuse me, healthcare associate, the HCA as we refer to them, is really our LPN and our MA. And these people have had to step up quite a bit in their role, start doing more than just what we used to refer to as roomers. They are now using tools that help them advance what they do in their daily practices. They have predetermined questions such as age-appropriate questions for well-child visits or adult physicals, questions that help prepare the provider when they come in. They're not having to do a lot of the base questions. They're there, they're answered, and the physician or APP can focus on those things that are key for that patient. They also do a lot of pre-clinic visit work, such as determining, based on protocols, what lab work needs to be done for which patient. So this helps them. Then when the patient comes in, the lab work is already back. The physician and the patient can meet and talk about those results. The physician and the healthcare associate are playing phone tag in the future with the patient because all that is able to be covered at the visit. And we did use MGMA ratios for our healthcare associate for the LPN level of staffing. Our last category is our patient service representatives. And our patient service representatives take all incoming phone calls. And this was a major shift from our practices. A lot of our practices had either nurse, the healthcare associate, or had an RN taking phone calls. And this was a huge culture shift for our organization to take phone messages transitioning to non-medically trained personnel. So our patient service reps had to start becoming trusted by the physicians. What questions were they asking? And one of the things we did find in many cases is our physicians felt they actually had more information from the patient service rep because they asked more questions and had more notes documented than the healthcare associate who assumed the physician would know these things. So physicians ultimately have found it helpful, but it was a struggle at first. We had to circle back around and do some more training of our PSRs, such as when do you use the scary list? What protocols per this practice are you going to follow, and what phone calls can you handle? We worked very hard to standardize administrative tasks, not clinical judgment issues, but more how we flowed and processed things. The other part that really was key is everyone on the team and the medical home team has to work to their highest potential to make the team successful. An example is a PSR, in addition to answering all the phone calls, registering patients, if they find that a healthcare associate is busy, will actually take the patient back to the room and be able to do the vitals and start the visit so that the provider is not delayed in their process, trying to minimize wait for the patient, but also help out their team members. We also went through in our RN specialists, our healthcare associates, and our patient service reps all receive a higher level of pay than equivalent positions elsewhere in the clinic for our specialty practices. And part of this is we wanted to attract the highest talent, but we also were expecting them to work to their highest potential and do more than we were expecting in other practices. This really has been a journey, and we don't see an end in sight. We're still proceeding down this path, and every day we're learning new things. As we go to the next step, I'd like to turn this over to Tim Loch.
Thanks, Jane. You're going to hear about the financial side of things now. You heard from the physician, the clinical side with Jane, and she has a clinical background. Now you're going to hear from the financial perspective and some of the outcomes. I think one of the things that, as you hear about Affinity, that makes us unique in a lot of ways is our relationship with regard to having our own health insurance plan. Years ago, we thought about selling the plan like a lot of organizations did. It was probably the best decision they ever made was to keep the insurance plan within the entity and the organization. Because I like to term this is the dollars and the data part of the presentation. When I go and I talk to others around the country about how are they implementing the medical home, it's always well, how can I add an RN specialist? How can I add an HCA? How can I pay everybody more? When I don't have the dollars to fund it, I'm still getting paid on a fee-for-service basis. So by having our relationship and owning our own health insurance plan, we're able to support the pilot today and the amount of $8 per member per month. Really helped us move forward. The other part of having the insurance plan is also the data that's available that we struggle with a lot of times in the clinics. Did Tim go get his prescriptions filled? Did Tim also get his screening at another clinic? Having the insurance plan and being able to pull that data together allowed us to push that data back to the medical home. So when we look at the gaps in care, we're truly getting what is the data that's coming through the claim system from the patients. You know, one of the things that was a caveat for moving into from the pilots, and let me approach that when Chris talked about the Kaukauna Clinic and the Kohler Clinic, it was a pilot. It was untested. Didn't know whether we were going to go forward with it or not. I think you'll see the results of those two pilots and what made us move forward with the full implementation and expansion of the pilots to all our practices. But we needed to move forward to NCQA accreditation. One of the bad things about owning your own insurance plan is the Office of Commissioner of Insurance. Every time we do a change or make a change in reimbursement, whether up or down, between our health plan and our medical group, we have to file that with the Office of Insurance Commissioner so that they do not feel that the funds from the members are being funneled to providers. So we have to get approval for every change that we make. So that's also a trigger for us. And again, I talked about how we're fortunate to have our own health plan focusing on the gaps in care. The $8 per member per month that you see up on the slide here, I think it's pretty consistent from what I'm hearing around the country. I've heard anywhere from $100 per member per year, $8 per member per month. We've actually had a few insurance carriers come and talk to us about their own products. Again, but focusing on the outcomes of their members at an $8 per member per month bonus payment possibility. With this pilot that we implemented, we're again fortunate that the health plan gave us $8 per member per month for every one of the members that are assigned to our PCPs. That caused a little consternation because they felt that there was a free rider effect for the other insurance plans that were not giving us the $8 per member per month. But in the end, as we take care of our patients, we think that with all the other bonus opportunities available, we'll be in good position for the future. Here's the outcomes. What you're seeing on the slide right now is what we were looking at in the middle of last year as to whether we move forward with the medical home to all our sites. We're always about a 3-month lag in outcomes and data. What you see here is the cost for professional services. So what do you want the medical home to do? You want the medical home and the patients to see their primary care provider more and bring the care there. So what you see on the left side of the graph is the NHP overall cost for primary care. You see that 18.6% increase in cost. Medical home was 33.5%. A lot of people say, geez, you're beating that. It's costing more. No, that's where we want to funnel the dollars for the care of our patients in the future. We need to get more dollars into primary care in the future. This supports that. You can see this, the purple graph, the bar is specialist care. You see the decrease in our specialist care. This has a lot of calls to me from our specialists about what are we going to do next year? What's going to happen? What's our role for the future? How are you going to address our compensation plan for the future when you see trends like this? And I think the overall is you see that we basically, in the medical home pilots, said our costs are flat compared to our NHP overall, which saw a 9.7% increase in their costs. The thing that is also relevant to this is we had fee schedule increases included in this at the same time that were a little better than the average as we were trying to catch up to the market for our own internal reviews. So that makes it even that much more impressive to see the overall cost at 0.62%. So there you see the professional side. Let's look what's happened on the hospital side. This is the one where I made presentations in front of hospital presidents, and they cringe in their chairs when they see what this data looks like. So this is the facility outpatient cost. This is what's done in the hospital outpatient, the inpatient cost. You can see, again, the outpatient costs 6.2% overall, comparable to what we saw there. But our inpatient cost, while in the time of this was pretty much in the heart of the recession, we did see inpatient costs go down overall within our health plan. It actually went down significantly more in our medical homes at 43%. And you can see the overall cost down 14.22% with regard to that. Our admissions were down in our medical home pilots 27%, inpatient days 42%. Outpatient registrations were down 5% at the same time. Now, look good, looks very promising, but it was still hard to generalize these two practices that were really very different practices of family medicine growing and internal medicine that was struggling to keep its head above water at that time. That was a very busy practice. So I think what we said is outcomes look good. The other things that to include in this is we looked at other measures other than cost alone. And our other measures of success for the pilots was what's happened with patient satisfaction, employee satisfaction, physician satisfaction, and also our quality scores. And we looked at quality scores as process scores and outcome scores. Process scores being, are you getting your screenings done for your A1C and your diabetics? Are you making sure you get blood pressure checks, et cetera, those types. And the outcomes would be the outcomes from those screening scores. So in all instances, our medical home pilots have some of the highest patient satisfaction scores in our system. It has the highest employee satisfaction scores, the highest physician satisfaction scores, and our quality scores in our medical home pilots from the start of the pilot to the end of the pilot all went up significantly in approaching the top 5 of the HEDIS measures as our own insurance plan has relayed to us. The other thing too is as we looked at this, we also risk adjusted the scores and the costs. So you can look at the costs that are here on the screen and say, what gross charges, what are gross charges? We also risk adjusted them for the acuity of the patients. And to give some perspective, the internal medicine practice that Chris spoke of earlier, that was a very mature practice, a lot of patients. The risk factor, if you look at all network health plan patients, have a risk factor of 1 is the average. When we moved into this, the patients that were in that practice assigned to that had a risk factor cost index of 1.16. Over the course of 1 year, we were able to move that down to the 1.0 cost index. That alone, movement, if we would have kept it at the 1.16 level that was before the pilot, would have been in excess of $1 million more in care that network health plan would have paid out. So that alone, when you look at the factors of the cost of the $8 per member per month to the benefit of the in excess of $1 million. Again, very different practice. Even at our family medicine practice, which had a cost index risk adjusted of a 0.93 prior to implementation, healthier patient panel, so forth, they were able to move down to 0.87 risk adjusted cost index through April of this time period. So both showed significant improvements in the risk adjustment scores. So we're sitting there a year ago saying, okay, we looked at these graphs, we see the graphs, our risk-adjusted cost indexes are trending in the right direction, and all the other measures for employee, patient, and our quality scores are good. The question was, can they be duplicated? I think at that time, the senior executive team of our system said, we have to do this. This is the model of the care for primary care for Affinity in the future, and we embarked upon expanding the pilot to all of our practices across Affinity, which is what we've been doing. And I think this week we file for, or in a few weeks we file for our last NCQA accreditation. Again, like everything else with our dealings, when we expanded the pilot, we need to go to the Office of Insurance Commissioner and let them know what we were up to and what we were doing. The other thing that was out of this pilot is that our hospitals are actually budgeting less admissions and patient days in the future based on the results of the pilot, which is a huge paradigm shift when you look at where we've trended in past years, where it's always been a very hospital-centric. We got to drive more admissions, we got to drive more procedures, more volume. We're taking the stance in our system and moving in the other direction, where we are anticipating our admissions to go down by moving into medical home pilots. Next step is, you heard me talk about the full implementation. We extended the $8 per member per month across all the practices. That allowed us to implement the RN specialists at various models at the levels you heard Jane talk about earlier, in place behavioral health specialists in selected practices. It also allowed us to put the physicians on a guarantee for the first year of their medical home. And we felt that was very important to get them engaged in the process, believe in the work that we're doing, attend the meetings, attend the huddles, because it's really moving from a physician-nurse relationship to a team-based relationship was, as Chris talked, a big cultural paradigm, and we wanted them to not feel guilty of seeing the patient, generating the RVU, and losing compensation because they're attending this meeting. We felt it was that important. At the start of every one of our implementations, we have 2 days of team training. And it was important that the physicians attend those at the same time. Again, we wanted to align the incentives to feel that they were not burdened by doing this. The next step that we're in the process of doing now is moving to a shared risk reimbursement with our health plan, moving into the future. And then we're also working on the integration of the health plan data, the claims data, into our ambulatory electronic record that allows us to really see better the gaps in care, be reported on those items that are outside of what's in our medical record that may have been care received at another location, practice, ER, pharmacy, etc. I can't have a discussion about physician practices without talking about the physician compensation plan. And that is true. One thing I do need to step back with the last slide. It's been a year since we've embarked upon the implementation in all the practices. We're still waiting for the final results as we move through this. But what we're finding to date is good. We're seeing the same trending results, not as pronounced as you've seen in the 2 slides that we've had. But what we do know as of right now is we have a greater acuity in the patients that we serve compared to the entire NHP population, and our costs are still 6% lower than the rest of the NHP population. So again, still trending in the same direction and looking good for the future. Moving back to the physician compensation slide, I want to make sure that everybody is fully aware that this is not a compensation presentation. We could talk for hours about physician compensation. If you've seen one model, you've seen one model. But what we have done over the last year is we formed teams of our physicians, the adult population, the pediatric population, and even our advanced practice nurse practitioners and PAs to develop plans of how we move into the future and move people off of the RVU treadmill, as we like to term it. So those were formed. They met throughout a year, 9 months, working through the plans. And 2 weeks ago, we got the final plan approved by our board of directors, and it's moving forward for implementation October 1st. And just briefly, the rewards that you see there: quality access, panel size, patient sat, all the stuff I was talking about earlier. You know, moving off this RVU treadmill is very significant. I have to tell you about an experience I had where I had a patient complaint. The patient complaint was their son went to see a pediatrician. She knew it was pink eye. 99214 was what was coded out. I could not throw a dart in the documentation that coded out to 99214. Mother gets pink eye 2 weeks later. She goes to our urgent care, gets a 99213. So we already know how confusing medical billing is and reimbursements. In our medical home, the protocol we have for that, we would have called in a script based on that. So we're really driving to get the physicians off of, you need to see the patient, you need to bring them in, to let's do what's right for the patient, let's do what's right for the care, and we'll call the protocol in based on what the physicians have devised, and you don't even need to see that visit, so the patient's taken care of. So that's what we're moving to. It's hard now. We got a foot in both worlds. You heard Chris earlier talk about 30% of our business is NHP. That means 70% of our business is still fee-for-service. And it's a tough straddle right now that a lot of individuals going through this will have the struggle with that. The last thing I'd like to say is this, by moving to this compensation plan, it really aligns the system with the system goals. Our board of directors have always focused on our quality measures, our access measures, our patient satisfaction measures, and of course our costs, which is really the income that's left available. So by moving into this compensation plan, we really feel that it aligns all the way down the system, from our health plan and our providers and our hospitals and so forth. So with that, I'll give it back to Chris.
Okay, I'm going to talk fast so we have time for questions. We're a little over time. Among the lessons learned, I'm going to summarize briefly some of the things that we've been talking about. Change management, everyone knows this is a big deal. If we had to do it over again, would we have each site hire staff from scratch or keep the existing staff? We'd have to think about that one, and Jane described the pros and cons each way. The RN specialists, initially we thought they would be more case management types of staff, and they really have evolved more into care providers. They don't do a lot of case management in the traditional sense. We also found that weekly group meetings have been key for the RN specialists to stay on track with protocols and to share ideas and share learnings. Provider engagement is really key. We've been talking about that throughout in all aspects of the team development and the development of the model, and also about collaborating across sites, which I'll mention a little more in a minute. Team development, the behavioral-based interviewing, the huddles, the role of the behavioral health coordinator as the team therapist sometimes, and to really facilitate development of the team. On the next slide, we have our future development. We're thinking now in terms of the medical neighborhood. There's been, as Tim mentioned, a lot of interest among specialists in what we're doing, and our core team is now reviewing all kinds of requests for specialty involvement in the medical home. There's a list of some of the potential projects. We actually have a pilot for an integrative medicine services within the medical home, diabetic educators going into the medical home and working with the nurse specialists. the COPD program Jane mentioned, and others that are either in process or being proposed. One of our next steps is to actively and formally involve the community. We're going to be setting up patient councils for each site. That will take some time to do, but that's I think really important. Primary care redesign is really a major part of our journey going forward, and we have a collaborative established of physicians and providers from all the sites to talk about sharing learnings and how do we develop the model further. And then we'll have to evaluate the impact of the compensation model. We're past year one, which was the salary year, and into the active model, and we'll see how that goes. Also under next steps, because the RN specialists ended up and the behavioral health coordinators not doing as much care coordination or case management as we had thought, we're going to embed a case manager from the health plan into a site as a pilot and expect that that will be spread. We will be doing ongoing audits, and we've actually started them to ensure maintenance of our processes and maintenance of the NCQA standards. Talked about the compensation model, and we're now in discussion with the health plan for a shared risk model, a commercial ACO, as it were, to manage the overall reimbursement from the health plan to the medical group. And I think that's it, so we're ready for questions.
Thank you very much. That was absolutely fantastic. At this point, we'll go ahead and begin to take questions. You'll see a question area in the bottom portion of your GoToWebinar controls, and feel free to submit your questions there. We have a number of questions that have already been submitted. Let me go ahead and get through these. We might not have a time to cover all the questions, but we'll do our best, and if there's questions that get left off during this Q&A period, we'll do our best to get those to the Affinity Medical Group for response. The first question is, once you've made the decision to move forward in developing the medical home, how long did it take to implement the policies and procedures and preparation necessary to meet the standards, NCQA standards?
A lot of the policies and procedures were developed with the initial medical homes and put into Affinity Medical Group wide policy. But each site probably varied up to 6 months to really feel that they were on the journey. There were, as you got your, put those processes down that they're in policy, let me take them in, and how does it fit into the flow of this specific department. And that probably took about 6 months to get that really in place.
Okay. Next question. What were the required skill levels for the healthcare associates and the patient service representatives?
The skill levels, you either had to have, from a basic skill, a certified medical assistant, or you had to have an LPN licensure to be qualified for the position. But then the behavioral-based interviewing took in much more your team approach, your ability to work well with others. We've had in other cases where people were great at what they did, but they weren't good with patient care. How did you interrelate with people? All those pieces became key to the skills that we hired for.
We also developed checklists. So for each of the 3 positions, the RN specialist, the HCA, and the PSR, there were 90-day checklists. So they had to meet basic requirements. Most of the PSRs were prior receptionists or would have that skill level, but then there were additional skills that they all had to add to keep their jobs. So they had a 90-day period to get checked off on specific skills, or they were not able to stay in the position.
Okay. Our next question was related to the case management on site. Is the case manager, is the case manager on site, and is the case manager full time in the medical home setting?
This is the sort of the next steps things. Of course, the RN specialists and the behavioral health specialists are full-time roles. The case manager who will be there from the health plan will be full-time on site. And this is our pilot, and it's starting in the next couple of weeks. Once we get a chance to evaluate that, I think the vision would be on-site and full-time unless they're out doing a home visit or something, and we'll have to see what ratio of patients to case managers that we need. We may end up having some sites sharing a case manager, but they're going to be there as opposed to in the health plan office.
Okay. Next question. Do you utilize registered nurses in any other capacity aside from the RN specialists? And can you describe a little bit about your ratios of MAs, LPNs, FTs related to each provider?
The RN specialist is the only role in primary care for the RN. We used to have RNs who did triage within the clinic, and we've taken that role away. So the RN specialists are seeing patients. Pediatrics still has some phone triage done by nursing based on the historical model and what has worked well. But the RNs primarily are doing the patient care visits.
Yeah. An RN could be employed as an HCA, but they'd be employed at the HCA wage scale.
Ratios?
The ratios that we worked with is we really looked at, we played with several different scores. We have something we call Wisdom, which tells us our outcome data. We looked at that number. We looked at data from the health plan. We also looked at panel size. We really felt the panel size was key, and by our experience, it confirmed where we were going with the 3,000 to 4,000 for internal med and 6,000 to 7,000 for pediatrics and family medicine, because the more chronic disease we saw in the internal med, and that's why it took more RN specialists for the panel sizes.
The other measures for the HCAs and the PSRs, really we tied them to the MGMA standards for those similar positions that you would look up under MGMA. And we look at the work RVUs because we felt that those are the people that are rooming the patient, taking the phone calls, and doing the work that's in front of them that day versus the RNs who are managing patients, calling patients, and doing the new work. So we kind of have a mixed model with that right now. Again, it's an evolving process for us.
Okay, great. Just a couple of questions regarding the financials. Does the physician compensation plan have a base and then the rewards on top? And can you allude to what that percentage roughly is and where you're headed with it?
No base. The compensation plan, we have a filling of the pool and the distribution of the funds. The pool is still filled with production and seeing patients. It's our expectation that there's at least a median level of production, plus then the incentives that we receive from the other insurance plans, Medicare, and so forth. But there isn't a base.
We budgeted what we would have paid under the old productivity model, which is what Tim's referring to as the pool, and as he mentioned, incentives that we're able to gain for quality P4P type things or this risk arrangement with NHP. The distribution will be in this coming year 55% based on productivity and varying percentages from 5 to 10% for things like access, patient satisfaction, et cetera. That'll make up the rest of it. And we'll go over the period of the next four years to 40% based on productivity and 60% based on the other measures.
Okay. Next question. In addition to receiving the $8 per member per month by the plan, was there any contribution from the hospital or any subsidy from the hospital to help with the process?
No.
Okay. Next question. You mentioned that the RN specialists and behavioral health specialists did not do as much case management as you had planned. Can you elaborate a little more on that?
We had thought originally, I believe, that they would do more of the care coordination, the coordination across the continuum of care, so that if a patient came out of the hospital, they would make sure they got in, or if they were in the ER, they got in, or connecting to community resources. They do some of that, but not as much as we had originally thought, because they've gotten really, as Jane has mentioned, into more positions of direct patient care and chronic disease management, and in the case of the behavioral health specialist, in counseling. That's why we think that we need the more traditional sort of case manager model who will help patients through the continuum of care from hospital to outpatient, from ER back into the medical home, et cetera, where we'll have some, I think, interesting discussions as this develops as how all of those roles overlap.
Okay. Next question. Have you considered centralizing call centers and upgrading them to more of a care coordination responsibility that would anticipate patients' needs regardless of why they called?
Oh, someday, but I think we're a little ways away from that. I think this completing our EHR implementation, I think is probably a prerequisite to that. We have some work to do with standardization of provider schedules, and I think we would aim towards that centralized call function, but we're not as far along the way as some organizations are.
Okay. Next question has to do with patient mix. Can you talk a little bit about does your medical home include Medicare patients, and if so, what approximate percentage were those patients?
Includes, you know what, we don't discriminate for Medicare, Medicaid, and so forth. So if a patient shows up at the practice, they get treated as if any other medical home patient that is, we get the $8 per member per month for. Medicare makes up about 35% of our practice.
Okay. Were there any specific clinical areas that perform better on outcomes than others, and can you elaborate on why that would be?
I think we had some early improvements in certainly in the process measures, followed by improvements in chronic. Now I'm thinking in terms of chronic disease, in terms of the outcome measures. And then some of the sites took a dip, and what we realized, or what we believed to be the case, is we were pulling in patients through the use of registries and the means available to us. We were pulling in patients who hadn't been in for a while, so they would come in, they'd be diabetic, and they'd have a really high hemoglobin A1C, but we were at least getting them in, whereas they had maybe fallen between the cracks before. So, Jane, can you think of other?
No, I think you're right. We had that dip, and since that dip, it steadily improved as we focused, again, first on process, and then as we got the processes in place, then the quality followed, the outcomes.
The other thing that, again, we're working on is the readmissions, and that's in coordination with the hospitals. We get discharges on a daily basis. We get in the clinics, we get listing of patients that we're seeing in the ER, and we try to manage the patients as to why they're going to the ER. Our Kohler Street practice has one frequent flyer that we just cannot get our hands around, and always wants to go to the ER instead of coming to the practice. But at least we identified them, and we're trying to work with them. So that's...
Transitions in care is one of our next big notions for the system.
Yeah.
Great. Well, we are just about out of time. I do want to thank Dr. Griger, Tim, and Jane, and the entire Affinity Health System for their time today. This was a very informative presentation. There were a number of questions related to if the presentation will be available after today, and we will have that posted online for you all within the PCPCC.net website. Just as a reminder, on Friday, October 1st, PCPCC will be holding their 5th annual summit, and I encourage everyone to register and join us in Washington for this event. And again, I want to give a nice thank you and warm appreciation out to Affinity Medical Group. It's been absolutely amazing amount of information in a short period of time, and they did a great job.
Thanks for having us. We had fun.
Thank you.
Bye.
Good luck.
Thank you. At this time, the webcast has ended. Thank you very much for joining, and be sure to have a great day.